Thank you everyone for coming along today, and as you can see, the title of my talk is Chronic Kidney Disease, and I'll be talking about the Oxford Renal study. So first of all, let me take a step back and talk about the department I work in. So I work in the Department of Primary Care Health Sciences. Primary care is services obviously provided by GPs, and it's about 90% of all of people's contact with the NHS. The department itself is a diverse mix of scientists and doctors. I myself am a scientist, and our research is recognised as being internationally excellent. We're ranked as the top centre in the UK for primary care. In 2008, this ranking is done every 5 years. We hope to be the top this year as well. And we have been judged the top for the last 15 years. So the research we're doing is important and is recognised as such. If you want to come along to the department, we actually have an open day on Saturday. So sorry, there's a little bit of advertising here. We're based on the old Radcliffe Infirmary site, round the back on Radcliffe Observatory Quarter, it's called. Opens at 9:30 and everybody's welcome to come. It's open to all the public. And you can see what we do there. So like all good talks, I've got 3 main topics. And I intend to start right at the beginning and talk about what kidneys do, and then move on to what is chronic kidney disease, and then what we're studying in Oxford, why we're studying it, and what's next. So sorry if this is a bit basic for everyone, but I need a common starting level. So the kidneys are a waste disposal system. They are basically a system that runs 24 hours a day, 7 days a week, 365 days a year, that sort out the recyclables from the non-recyclables. There's 2 of them. They're at the back, just under your spine, surrounded by a layer of fat, or quite a big layer of fat in my case, just to protect them. And they work by blood passing in through the renal artery, being processed by something called a nephron, and I'll come on to more of that later, and then the clean blood is passed back into the body and the waste is excreted through the urine. Now the nephron is the functional unit of the kidney, which you can just see over here. So it's a tubular structure, and you have something called the glomerulus at the start, and the glomerulus is the part where you've got a nest of capillaries where waste products and substrates are filtered from the blood, and then you've got about 1 million of these, of which you probably lose about 100,000 of them per decade. That's 1 million per kidney. So there's an age-related decline of these nephrons in your kidney. And the tubular structure is about 50 miles long if you was to connect it up. I'm not sure who calculated that, but there's a lot of filtering going on in your kidneys. So what do the kidneys do? Well, there's 3 main aspects. There's lots of things the kidney do, but the 3 main ones are it regulates water. So you're about 66% water, and it maintains the equilibrium between the intracellular, so that's the water in your cells, and the extracellular, that's the water everywhere else, in your blood, in your plasma. And it maintains an equilibrium between those 2, and the main way it does that is by excretion of urine. So there's a hormone called ADH, or antidiuretic hormone, that's secreted by the hypothalamus, and that tells your kidneys to push out more urine if you've got too much water on board. The second thing it does is look after salts. So sodium and potassium being the 2 main salts it looks after. Most of these salts are all these salts are dissolved within the fluids. Now the main component, sodium, is all extracellular, and potassium is within the cells. And not having the correct balance of salts within your body means that you can develop something called edema. So where fluid accumulates in compartments where it's not supposed to be, and you can get fluids and swelling of various joints and ankles and elbows. The third thing it does is the acid balance. Now, the main excretion of acid is actually through the lungs. So you breathe out carbon dioxide, but the kidneys have a vital function. There's fixed acids that can only be secreted by the kidneys. There's no other way to get rid of them. And the acid balance keeps your blood at a normal pH of between 7.2 and 7.45. And when this becomes perturbed, your kidneys kick in and start secreting the acids. And the third, on top of those three things, kidneys also produce hormones. The three main things the hormones look after are the blood pressure through the renin, angiotensin and aldosterone system, which is a very complex way of talking about tightening your blood vessels to increase your blood pressure. They look after your calcium and bone health through vitamin D, and they actually manipulate vitamin D into an active form. They also look after and help produce red blood cells in the marrow of the bones through a hormone called erythropoietin. And when things go wrong, you get hypertension, so you get high blood pressure, you get bone diseases, and you get anemia. So that's the basic of what the kidneys do. The question is, how do we measure it? How do we tell they're doing a good job or they're doing a bad job? Well, you can directly measure it. So you can measure kidney function. You can inject something into the body that is not secreted or absorbed by the kidneys. The common one to use is inulin. The advantage is it's very accurate. The problems is it's invasive because you're injecting a substance into someone. It's often inconvenient and it's costly. You can also measure kidney function indirectly, and that's commonly done by just looking at waste product, so something that you can measure that you haven't put into the body. The disadvantage is obviously it's not as accurate. It is non-invasive though, and it's convenient and it's cheap, and this is what's normally done. And the waste product we use is called creatinine. Creatinine is a waste product that comes from muscles, but it can be affected by the age of the subject, the sex or the gender, or the ethnicity, and of course muscle mass. So there's a big difference between someone who's got a lot of muscle mass and somebody who doesn't have very much at all. Now this paper, I've stolen this graph from, just shows, if you look along the x-axis, the amount of muscle mass that's in the body compared to the amount of creatinine that's in the body. The more muscle mass you have, the more creatinine you can possibly have. This isn't always taken into account when measuring the creatinine. But there are functions and formulas and mathematical equations that can help us. So the most common one that's used is called the modification of diet in renal disease equation, and it gives us something called the estimated glomerular filtration rate, the EGFR. Now that does take into account age, sex and ethnicity, not muscle mass, and another disadvantage is it's not great for measuring kidneys in people in primary care. It was based on a secondary care population, people who had already been discovered to have the disease and were quite advanced. There are more equations on the way that try and overcome some of these shortcomings. One's called the CKD-EPI, and there's another product, substrate you can measure called cystatin C. I'll talk a little bit about that one at the end. As I mentioned earlier, there is an age-related decline in renal function. We lose about 100,000 nephrons per decade of life. It's not exactly clear why. We still don't know. We don't know whether it's through comorbidities, so that's other things that you will have wrong with you along with chronic kidney disease, whether that's diabetes, your hypertension, or anything else, or whether it is just the physiological decline and that there is nothing we can do about it. The answer is we don't know. We don't know yet. But it is true. So this paper is from Kidney International about 4 years ago. So along the bottom axis here, we've got age in decades, starting at 20, and we have an MGFR hit on the y-axis, so this was actually a direct measure of glomerular filtration rate. And as you can see, in these perfectly healthy, normal, these were prospective kidney donors before they donated. You can see there is an age-related decline both in women and in men, and they're pretty much the same. So just to summarize the kidney primarily acts as a filter for waste in the body, or as a recycling system for useful things in the body. We can measure the filtration rate directly by adding a chemical, and we can estimate the filtration rate by just measuring a waste product. And the kidneys change naturally as we age. So what is CKD? What is chronic kidney disease? Well, like all good researchers, I just Googled it to get the current definition. It turns out Wikipedia says it's one of the largest engineering companies in the former Czech Republic. So I thought I'd better go to the NICE guidelines, the National Institute of Clinical Excellence. Now they define chronic kidney disease as a long-term condition where the kidneys do not work effectively. It's common. So their definition of common is it affects about 1 in 10 people. It's frequently unrecognised, so there's no symptoms until later in the disease progression. And as I already mentioned, it's often comorbid, so it often comes along with other diseases, and that's normally when it's detected. So you come in with hypertension and you're then diagnosed with CKD, or you have diabetes and then they discover CKD. It's split into 5 stages in terms of your glomerular filtration rate. It uses a very strange unit here, don't worry about that. But stage 1 is defined as you have a normal filtration rate, but there is something else going on. So along with that, there is evidence of kidney damage. So that's normally diagnosed by protein in your urine. So there's protein slipping into your urine. The second stage is your glomerular filtration rate, your GFR, is decreased down to 60. And again, there's evidence of protein in your urine. Stage 3 is when it's normally picked up. So stage 3, your GFR has dropped down to about 60. And the reason stage 3 is split into 2 categories, A and B, is because this is where the most work has been done on cardiovascular risk. And it turns out there is a big difference between being in stage 3A and 3B in terms of your cardiovascular risk. Between 4 and 10 times as much as somebody with completely normal GFR. Stage 4 is when you're normally transferred to secondary care, and stage 5 is defined as end-stage renal failure, and that's normally when you have renal replacement therapy or dialysis. So why is it important? I've already alluded to one of the risk factors, but this is the classic graph from O'Hare. It's a 3D graph. So along the x-axis, we've got the estimated glomerular filtration rate, all the way from end-stage renal failure to normal. On the z-axis, we've got age in increasing, is it deciles? Increasing groups. And mortality is the y-axis. So you can see if you've got a normal filtration rate and you're relatively young, you're not at particularly high risk of dying at least that year. As you get older, obviously you're more increased, your risk of dying increases. But also, as your filtration rate decreases, so does your mortality risk. And the combined effect of age and decreased filtration rate greatly increases your chance or your percentage mortality risk of that year. I talked briefly about protein in urine. Again, the classic graph here shows age on the x-axis, albumin, or the amount of protein in your urine, on the z-axis, and mortality on the y-axis again. So you can see somebody who is relatively young, who has no protein in the urine, it has low mortality. As the protein increases, your mortality risk increases along with your age. So the older you are and the more protein you have in your urine, the increased likelihood of mortality. Now, this is the latest breaking news straight from the Lancet. This is pretty new stuff in July. So in terms of chronic kidney disease, this is the current best evidence. Now, this one graph is based on 14 million individual data points. Again, if I just briefly talk you through the axis, along the x-axis we've got estimated GFR, and here we've got your risk of cardiovascular disease. 1 being normal risk, anything above 1, you're at increased risk. And you can see here that for somebody with a normal GFR, you're quite happy having no increased cardiovascular risk. But there's a threshold effect around 75. Now, that's not currently reflected in the guidelines, which says that below 60 you should start to worry. There's something happening around 75. And at 75, you can see someone in stage 3 CKD has about twice the effect, twice the increased risk of cardiovascular disease. Stage 4, you've got about 3 times the effect or hazard ratio for cardiovascular disease. From the same paper, it also looks at protein. So ACR is the albumin-creatinine ratio. So basically, the amount of protein in your urine divided by the amount of creatinine in your blood. And you can see there's no threshold in this graph at all. It's pretty linear. Now, the cutoff currently in the guidelines is 30. So you're normal if you're below 30. If you're above 30, your doctor starts to worry. But you can see here, at 30, you're still at double the risk as somebody who has 0 for cardiovascular disease. So even slight amounts of protein in the urine is important. There's also other reasons. So it's a risk factor for cardiovascular disease. It's the primary cause of mortality in this group. It's also the primary cause of morbidity. It's a risk factor for all-cause mortality, and unsurprisingly, it's a risk factor for end-stage renal disease. Now, not everybody who has CKD progresses. About 1.5% progress. 1.4% of people with chronic kidney disease on diagnosis will progress to end-stage renal disease. And that's a maybe, because we're not exactly sure, because we don't exactly know how many people have it. Unsurprisingly, it's a predictor for hospitalization. It's a predictor for poorer quality of life. It's also a predictor for cognitive dysfunction. And 2% of the entire NHS budget is spent on renal replacement therapy. That's £2.2 billion. It's a lot of money. Now, 2 billion is a difficult number to comprehend. Numbers are bandied around a lot, but let me try and put into perspective the figure of 2 billion. So 2 billion seconds ago, it was 1949, and NATO was established. 2 billion minutes ago, the pharaohs were ruling Egypt in 1800 BC. 2 billion hours ago, the first anatomically correct human appeared. That's 220,000 BC. 2 billion is a big number. So are we diagnosing chronic kidney disease correctly? Well, yes and no. The MDRD formula, which I showed earlier, may be good enough for now and is the current recommended one to use. There are other formulas on the way. It's not cost effective to screen everybody for chronic kidney disease. And there are regional health inequalities. So although primary care trusts don't exist anymore, this data is still correct. So along here, we've got all of the trusts that make up the entire of England. And up here are their published prevalence rates. This data is estimated on laboratory results. So only people who ever had a blood test will ever get picked up. So that's one small problem with it. But this is the best data that exists at the moment. And you can see that it seems that people who live in the richer areas have lower prevalence of CKD. And people who live in poorer areas or areas that perhaps aren't as are more deprived than the areas at the lower end of the graph have much higher prevalences of CKD.
Is Scotland included in that?
It's not. This is just England. So why? Again, we're not 100% sure, but there's possible factors. It could be diet. It could be amount of exercise undertaken. It could be levels of obesity, levels of smoking, or again, it could be higher levels of comorbidities in those areas. A lot of work needs to be done, especially in primary care. So a brief summary of chronic kidney disease. So chronic kidney disease is now recognised as a major public health burden. It's the next thing on the agenda for the NHS. Prevalence is up to 10%. In high-risk populations, such as people who already have diabetes, it can be up to 50%. Chronic kidney disease independently increases your cardiovascular risk, and clinical prognosis is related to both your independently to your filtration rate and any protein in your urine. And CKD independently increases your risk of death, your risk of mortality. So what are we doing in Oxford? Well, I've already highlighted there's a lot we don't know. A lot of work has been done in secondary care, not a lot has been done in primary care. And the difference between primary and secondary care is, in secondary care, you already have been diagnosed with the disease. You're already halfway down the pathway in chronic kidney disease. You are normally already in stage 3 on the 1 to 5 scale. So in primary care, we need to figure out what's the best way of determining someone has chronic kidney disease. How many people even have it? You can see the massive diversity on just the English primary care trusts. What happens to those individuals over a longer period of time? And most importantly, why do kidneys decline? And why do some people decline a lot faster than others? So why does their filtration rate decline faster? So the Oxford Renal study, or OxRen, it recruits from primary care. Now it's based in the Thames Valley, but it's demographically representative of the UK general population. So we're stratifying our recruitment so that we represent the whole of the UK. So it's not just Oxford that it will apply to. There's 6,000 patients who are to be recruited, 1,200 who will have CKD. We estimate based on the best prevalence estimates we have. There's a 10-year follow-up, and it's funded by the BRC. So the primary aim of the study is to establish the prevalence, the incidence and progression of chronic kidney disease in a population demographically representative of the UK. So the main inclusion criteria are you're healthy, male or female, aged 60 years and above. The reason for choosing 60 years and above is there was a paper published by our department in 2010 that tried to work out when most people are diagnosed with chronic kidney disease, and it showed a definite threshold effect at 60 years of age. Anyone below 60 years of age is unlikely to have developed CKD unless they're already displaying other symptoms that have normally been picked up, such as protein in their urine or family history of kidney problems. Now, to be as inclusive as possible, we only have 3 exclusion criteria. So you're either terminally ill, you've previously had a solid organ transplant, or the catch-all, the GP doesn't feel that patient's appropriate for the study. And that's down to a clinical decision. That seems a little odd on my screen, I'm not sure why. Basically, there's 11 GP surgeries that will be recruited. They will then contact about 16,000 patients who are on their registers, on their books. We expect about a 40% response rate from those patients. And of those, we will send off 6,000 sheets of paper to tell them more about the study and see if they're interested. There will already be data on the GP systems. I apologise for these slides. So there will either be no diagnosis of chronic kidney disease. They might have a blood test somewhere in their history that has shown that they've got impaired kidney function, or they will be diagnosed already with having chronic kidney disease. So we will end up with a cohort of patients who have no kidney disease, who have something called transient CKD, which is where they've got one positive result but then a negative result, and chronic kidney disease, which is defined as 2 positive results for chronic kidney disease by glomerular filtration rate or protein in your urine within the 12 months, at least 3 months apart. And then we're going to follow up the chronic kidney disease cohort for the next 10 years with an annual assessment. So going back to the primary aim again, let me expand on it a little bit. So we're going to establish the prevalence. This prevalence is just the proportion of a population who are found to have the disease. So everybody will come along to a screening visit. So somebody's invited to the study, the GP records are checked to see if they've got any existing results within the last 12 months. They come along to a screening visit at their GP surgery where they have a blood test and a urine test, and if they have a positive result for chronic kidney disease, they're invited back for a second test. That's 3 months later. In 3 months, again, if they have a positive result for chronic kidney disease, they're included in our chronic kidney disease group. We also have something called borderline results for chronic kidney disease. Because we know creatinine is a messy waste product, we allow a small intra-individual variation in that person's creatinine level. And it's generally accepted that you allow about 5 millimoles per minute per 1.73 meters squared for each individual. And that's because your creatinine level also depends on what you've eaten the night before. So if they are on borderline and they test positive the next time they come along, they're recruited in the CKD group. By knowing how many people have chronic kidney disease and how many people we had in our cohort, we can just establish within our cohort that's demographically representative of the UK, the estimated prevalence for the whole of the UK for chronic kidney disease. The second part of the primary aim is to establish the incidence. So the incidence is the measure of risk of developing the condition within a 1-year time period, the number of new cases. So we have a lot of people who we know do not have chronic kidney disease because we've tested them. We've tested to see if they have it. So that's going to be 4,400 patients who we know don't have it. So a year later, we're going to test them all again. We're going to invite them all back, and hopefully they're all going to say yes, and they're all going to come along, and they're going to have a blood test. And if they test positive, they will have 2. The third part is the progression. So I mentioned already that we're going to follow people up, and we're going to follow them up to see how people's health changes in the future. So there's an annual visit. There's 5 years initially, because that's how much we got funding for, and then we're going to do 5 more years. We're going to follow people up through their GP surgeries, but also through hospital admissions and something called the Medical Research Information Service, which basically tells us if people move away or they die. We're also going to do something called biobanking. So along with taking blood and urine samples, we're going to take some of that and we're going to freeze it, because we don't know all the right questions now. And in the future, we might come up with a new question, and we can go back to all the blood and urine we've stored and ask that question right back at the beginning of our study. And we're going to measure a lot of things. We're going to measure demographics, and if we have missed anything out on here that people think, well, you should probably be thinking about, I'll be welcome to add it in. But we think we've covered pretty much everything. So we've got age, ethnicity, educational status, residential postcode, clinical history, past medical history, family history, smoking, alcohol abuse. You can read it yourself. We're going to do blood tests, and we're going to measure a lot of things in the blood test. Basically, those forms that the GPs tick to say what blood test you're going to get, we're going to tick all the boxes and get everything done. We're also going to get something that I mentioned earlier called cystatin C. And cystatin C is a new one. And the reason we're going to measure that is because it will replace creatinine as a measure of glomerular function in the future, because it's not affected by age, ethnicity, muscle mass. Going to do a urine test where we measure the protein. We're going to do blood pressure phenotyping, and all that means is we're going to look at the blood pressure in a number of different ways. Going to measure it in the clinic, going to give people a blood pressure monitor to take home and measure their blood pressure over a typical week, just twice daily. Some people will get a 24-hour blood pressure where they will have, if they so desire, they will take the blood pressure 24 hours a day and submit the results back to us. There's also a new technique called pulse wave analysis, which is just a fancy way of calculating how stiff people's vessels are, blood vessels are. Again, we've only got about 12 of those machines because they cost about £5,000 each. And we're going to give them out for people to take away, take home and measure their blood pressure. And the reason we're getting people to take them home is because there's something called white coat hypertension. When you come into the doctors, you're worried your blood pressure is going to be high, your blood pressure is high. So hopefully in people's home environment, the blood pressures we get will be real blood pressures. Going to do a lot of questionnaires as well. So there's the quality of life questionnaire we're going to do a diet questionnaire, an exercise questionnaire, and a cognition questionnaire. We're also doing a lot of secondary outcomes. How am I doing for time? I've got a little bit longer. So we're going to work out the percentage of participant by chronic kidney disease stage who on rescreening of the entire cohort are diagnosed with CKD. Do people just get suddenly diagnosed as stage 1? Are they diagnosed as stage 3? Have people progressed in the normal undiseased, unchronic kidney disease cohort faster than we expected them to. We're going to look at the people who progress really, really quickly. This is defined as rapid renal decline, and it's if you're declining, as I mentioned earlier, you decline because you're losing nephrons, so you lose about 100,000 per decade of life. That equates to about a 2-unit difference in EGFR per year that you're losing, just naturally, we think. Some people decline greater than 5 units per year. And it's those people that are most likely to progress to end-stage renal failure. So we're trying to pick them up earlier than we would normally and see what makes them different. We're going to look at the rates and determinants of progression of CKD, and we're going to do that every year. We're going to try and work out predictors of cardiovascular events, and we'll only be able to do that after a long period of time when we've got a lot of data and we can look back at how people were 10 years ago perhaps and see what happened over that 10-year period. We're going to look at any changes in those 20 plus characteristics and data points we're measuring. Any changes in blood pressure phenotyping. We know blood pressure is important. We're going to look at the different measures of establishing CKD. So we're going to compare this MDRD equation with the other measures that we're using, the new cystatin C measure and the new coming CKD epi equation. We're going to look at the cost effectiveness of this because the NHS is very interested in spending the money to get the maximum effect, to spend the money and really see a real benefit to the patients. So we're doing a cost-effective analysis that will look at rates of adverse events, all-cause mortality, and compare the different methods of estimating the glomerular filtration rate. So the results so far. So of the 11 practices we wanted, 14 have come along and said, yes, we'd love to do this study, which is great because it's more than we wanted. We've accepted 8 of them because not all of them are suitable because we want to have a diverse mix to match the UK general population. But these 8 practices cover a patient population of about 60,000 patients, of whom are over 60, about 14,000. So we do need some more practices. As I said, we want to be representative of the UK general population, so we're using something called the IMD Score, which is Indices of Multiple Deprivation. They look at financial, health, education, services in the area or crime, and this is a government measure, and they classify each area of the country according to an IMD score. Now the UK median IMD score is about 17.3. Our current is 16.4, so we're not quite there yet. We need to work on our recruitment to try and push ours up to the national average. So OxRen will establish the prevalence. Now you're going to have to come back next year for the answer to that one. Because we've recruited everyone, we'll know how many people will have it. The incidence, you have to come back in 2 years. Progression, you're probably going to have to come back in 5 or 10 years. However, if you want to be kept up to date, you can always email us. We're always happy to talk about our research and talk about our science. And there's a lot of further work ongoing. So OxRen is part of a wider strategy for chronic kidney disease within primary care and especially within our department. So OxRen is one of 3 current studies. And there's at least 3 more studies in the area undergoing planning or funding stages. Now we define the programme that encompasses all of these as the MORSE programme, very Oxford-centric. And we came up with the acronym before we came up with the words that fit it, but it stands for the measuring of renal specific endpoints. So the MORSE programme, so CKD, It's not enough just to detect chronic kidney disease. We need to work out the best treatments for it, within primary care especially. And once we've diagnosed someone with chronic kidney disease, we need to know how often to monitor them, how often to get them back in to see what's happening. So under the detection, how should we be best detecting it? Which of those formulas should we be using? Which of those substrates in the body should we be measuring? Should we be measuring cystatin C? Should we be using creatinine? We don't quite know yet. Under treatment, which patients will go on to have vascular events? We'll find that out in the future, or indeed will have a fast decline in renal function. And how do we reduce those risks? And monitoring, what are the optimal monitoring interviews? How often should people be having blood tests? At the moment, we just don't know. However, there are 3 studies underway in Oxford that will hopefully answer that. So the detection one is primarily OxRen. There's another one in treatment called BARAC-D, and there's a third one on monitoring called Form 2C. They're all within our department. OxRen I've already pretty much covered. BARAC-D is recruiting patients who already have been diagnosed with chronic kidney disease, stage 3B. So those are people who already known to the GP practices. It's multi-centre in that it's UK-wide. It's not just based in Oxford. Oxford's leading it and is one of the centres, but it's UK-wide. Something called a probe design, which just is a technical way of saying we will not know who's on what drug when we analyse the results. And we will give half the patients involved a diuretic, so they will pee out more. And by peeing out more, we hope to reduce their blood pressure and therefore improve their chronic kidney disease. But we're giving them something called spiralactolone, which has also been shown to have a good effect on cardiovascular disease, as well as preserving that renal function. It's called a potassium-sparing diuretic. The third one is Form 2C, which looks at how frequently we should be monitoring them. And that is a big study that is going to work alongside OxRen, looking at the creatinine and cystatin C levels in newly diagnosed people with chronic kidney disease. So this is the last slide, I promise. I always like to know when a lecture's finishing. So kidneys, they primarily act as a filter and recycling centre for waste in the body. Chronic kidney disease, it's a major health burden, is now recognised as such, and it independently increases cardiovascular risk and overall mortality risk. And OxRen will answer 3 main major questions. How many people have chronic kidney disease? How many people develop it? And how people who have it will progress? And overall, OxRen is part of a larger programme of work within Oxford. I'd like to acknowledge everybody who's involved in everything. The PI of the programme is Professor Richard Hobbs, so he's my boss. So any fan mail about me, please send to him. So thank you very much for listening. Happy to take questions.